Well, thank you, everyone, and thank you to Bruno for the opportunity to present. So we wanted to show one case from a surgical perspective, and we'll get back to the screen here. So I'm in Chapel Hill, North Carolina, here at University of North Carolina. And this is a case of a 6-year-old girl with a left proximal humerus lesion. And the history was that she's right-hand dominant and had about only a short course, only about a week of left shoulder and upper arm pain without an apparent inciting event. And she had pain that was waking her up at night and then with any movement. Really unremarkable personal and family history. On physical exam, she had tenderness around the proximal humerus and a firm swelling and deep mass in that same area, and really had any pain with attempted active or passive range of motion of the shoulder, and then an unremarkable neurovascular exam. And then these were the plane radiographs that were obtained on her initial visit. And so there you can see a AP and a lateral view of the humerus. And does anyone have any comments to make on this, or Bruno, should I just keep progressing through the imaging first?
Yes, just go ahead.
Okay. So as you can see, she had a very ill-defined, aggressive appearing lesion of the proximal humeral metaphysis with, almost classic appearing Codman triangle and extension into the soft tissues. And quickly thereafter, she had an MRI. We'll just show a couple of selected axials. So on T2, you can see there's the osseous involvement and a big extraosseous mass. And then on the post-contrasted images, this is almost at the level of the glenoid. You can see part of the glenoid in the field of view. There was almost some of the mass abutting the glenoid. And more distally, you can also see the mass did not involve the medial neurovascular bundle, but was at least encroaching on those structures. So and this is the coronal T1 image, just showing the extent of tumor proximally and then distally. So at that time, she underwent a percutaneous CT-guided biopsy. And here you can see a low power photomicrograph of the specimen. And then the next one is a higher power view. And the diagnosis was high grade conventional osteosarcoma. And she was subsequently started on chemotherapy after staging studies showed no other osseous lesions or concern for any pulmonary metastases. So she underwent neoadjuvant chemotherapy and had really an excellent clinical response to systemic treatment, both in terms of size of the mass and in terms of pain level. And here you can see an axial T2 image, almost at the level of the joint, where you can see significant regression of the tumor proximally, and then a T1 image distally showing similar regression in terms of the extraosseous component. And then this was the coronal T1 image at the conclusion of chemotherapy, again showing that extension almost from the humeral head all the way down to about 3 to 4 centimeters above the fossa in the distal humerus. And so at this time, we were confronted with the issue in terms of the best surgical option for local control. And these were the various options that were discussed or at least considered at this time. Any discussion at this point, Bruno, or should I carry on to what we did?
No, Eugen is now putting up the questions
Okay.
so that we can elect.
I did not receive this question, so
Oh,
it's
okay. So then please just proceed.
okay. So at this point, after considering these options and discussing the various options with the family, we elected to proceed with limb salvage procedure with then a free fibula transfer. So here are just a few intraoperative photographs. Here you can see the extent of exposure, proximal to distal. The deltoid was quite scarred down to the tumor, which was suggested on the pre-surgical imaging. So we took deltoid with the proximal humerus. But then, aside from the axillary nerve, the other nerves were fine. There you can see after making our distal cut just above the fossa, mobilizing the tumor from distal to proximal. And then this is the tumor bed after resection. And there you can see the glenoid on the right side of the view. There's the specimen, and then there's the free fibula that our hand and microvascular colleagues took from the contralateral leg and then mobilized. And there's the intraoperative photo of the fixation, and then the immediate postoperative photo of the proximal fibula now serving as the proximal humerus. This is a bone scan not long thereafter, a few months later, showing some activity in the proximal humeral physis, or proximal fibular physis in this case. At this time, she underwent really uneventful adjuvant chemotherapy, still no evidence of metastatic disease. It was doing well and was back at school, and then fell at school about 18 months postoperatively. And there you can see that she sustained a fracture through the fibula in the mid shaft at that time. We again discussed various treatment options for this fracture, and then elected to treat it the way we would a typical isolated humerus fracture, and treat it with non-surgical management. And this is about 6 weeks after that, and you can see some early healing, and then remodeling at about 3 months after that fracture. And at this point, she has a really excellent elbow and hand function, and overall poor shoulder function in terms of active forward flexion and abduction. And we've discussed various options with the family. At this point, they're comfortable with her current level of function. And so we had discussed observation and even consideration of possible shoulder fusion at some point. But this time, the family is very comfortable and happy with her progress and overall level of function in the hand. So we've chosen to observe for now. These were the, in terms of the take-home messages, so to speak, of this particular case, and that the initial staging studies were quite dire looking in terms of limb preservation, but she had a really outstanding response to chemotherapy, and we were able to proceed with the limb salvage approach. And as we all know, all various reconstructive options have possible either short or long-term risks and adverse consequences. In this particular patient, in some respects, we're still managing some of those longer-term adverse issues just in terms of her overall shoulder function, although we're successful oncologically and at least successful in terms of hand and elbow function. So, and I think that's the final slide. So,
well, Bob, thanks so much for this interesting case. I would love again to open the discussion with the panel. And today among us is Manish Agarwal from India, Philip Funovic from Vienna, Frank Traub from Mainz, and Konstantina Irani from Bologna. So maybe just speak up.
So can I go
you,
first, Bruno?
Please, please.
So one question for Bob is, when I looked at the pre-op MR, I thought it would be safer to do an extra-articular resection rather than the intra-articular that was done, considering that the tumor was there. But then with such a good response to chemo, I think one does get tempted to do an intra-articular resection. And I just wanted to know how safe it is. Conventionally, we are always taught that the margins have to be based on what the pre-operative or pre-chemotherapy scans showed, rather than after the shrinkage of the tumor. And the second question was that you did a proximal fibula that is with a live growth plate. That means the growth plate was live at that time. But this was based on the peroneal artery, from what I could see from the pictures. Isn't the growth plate vascularity actually coming from the anterotibial vessels rather than the peroneal vessels in such a case?
Yeah. So for the second question, that's a great point, and I would defer to my microvascular colleagues on the vascular supply issue. There's activity in the physis on the bone scan, but in terms of the way they did the reconstruction, I would defer to them. So I don't have a good answer for that. For the, I think the intra versus extra-articular resection is a great point, and it's one that I lost a decent amount of sleep over in this case, just thinking about the various options. I totally agree. The way the pre-op imaging looked, it would have necessitated an extra-articular resection. But the response was so dramatic in that area with chemo that that it became safer in our collective estimation here to do an intra-articular resection. But no, your point's very well taken about the amount of involvement proximally.
I think, Manish, if we look at the papers looking into intra versus extra-articular resections in the knee joint, we haven't really been able to identify an advantage in survival in terms of extra-articular resections. But I agree that, again, in the shoulder area, it makes not much of a functional difference to take a slice of the glenoid and by that have more security by aiming at an extra-articular resection, because in the shoulder, the difference basically, especially when we have to reconstruct it in a way that will not result in any abductor function, makes no difference whether we let the fibula articulate against the normal glenoid or just the resected bone of the scapula.
Mm-hmm. Yeah, I think that's a very fair statement.
Yeah. And concerning your second question, I literally had the same question, but then in our last case we did we were taking the anterior tibial artery as the pedicle, and this is much harder to harvest because then you have to dissect some branches of the peroneal nerve, and patients end up in a worse foot function. And our last patients where we did that in order to save the physis actually ended up in having a skipped fibula physis of the shoulder. So again, we had an avascular necrosis of the epiphysis of the fibula. So I think it's just a tricky question. And this in that regard, Bob, I would like to ask you, when you had this fracture, my biggest concern in these fractures is that the fracture, especially in the early post-op phase, could eventually disrupt the pedicle. Do you use bone scans in order to check on the vascularization of the proximal fragment?
Yeah, so she got some routine bone scans fairly frequently in that initial postoperative period. And then this fracture occurred, it was about 18 months postoperatively. So we were fairly certain that the vascular supply was intact. But your point's well taken regardless. But I think we were far enough out from the surgery that we were more comfortable with the overall vascularity of it at that point.
Okay, so I think you did a great job. In our last patients, I mean, children with osteosarcoma of the proximal humerus, we start to do a composite prosthesis with a resurfacing prosthesis, using also, a fibula because, we need a small bone. So this could be another option. But, you did a great job, and I think this is a very good option. And when we use fibula alone, we try to protect the fibula with a longer plate. So this is my only question: why you didn't use a longer plate at the beginning?
It's a great question. That was my question too for my hand colleague.
I mean, this was a great surgery. I mean,
oh no, and it worked fine. But I had the same question,
and we have a wonderful result secondary to a fracture that is amazing. So
yes, but no, I had the exact same question and was told that it was fine. So
okay, thank you very much.
Do you have any experience with non-vascularized fibular grafts when you do reconstruction? I mean, not for this case, but in other cases, do you always use fibulas, vascularized fibulas, or do you also keen or familiar with non-vascularized fibular grafts?
I do not personally have experience with non-vascularized fibula. I don't know if others do.
Yeah, we used the non-vascularized fibula, a week ago in a 4 years old child, so a very small patient, and a vascular fibula in a 4 years old boy is a very demanding surgery. We prefer to use an allograft. So, but we performed surgery 1 week ago. So,
I think for diaphyseal defects, the non-vascularized fibula works quite fine. But I think as soon as you go to a articular defect and want to reconstruct the proximal humerus and the shoulder joint, then it requires rather vascularized, at least in my experience. But
I mean, for this case, it makes sense because otherwise you would have no bone growth because you don't have any physis left. Especially the elbow joint is not the part where the bone actually grows. But as you mentioned, for the diaphyseal defects, and then I don't know if it makes any differences if you go to the lower part of the body or the upper extremities. A non-vascularized fibula graft could also be very handy, and it's much easier to handle this kind of operation than do all the microvascularized colleague stuff, and yeah, it's much more demanding.
Sorry to jump in. May I do an announcement? I'm a Dr. Palmerini, a medical oncologist, and I thank Dr. Escher for discussing this case. And we did not mention the option of chemotherapy, adjuvant chemotherapy in case of local only relapse. We are collecting now all the cases of osteosarcoma with local only recurrence as first relapse within the MSOS and also foster networks. So I would be glad if any of you would like to join this prospective collection. We did show no difference in a retrospective series among patients with no chemotherapy, and at the moment we don't recommend it as unlike special cases.